Bismillahirrahmanirrahim. Assalamu alaikum, my dear family, and we are back with our new episode, which is episode number 3 about acute coronary syndrome, which we also call ACS. It is a part of our CVS lecture series, and let's get started with it. Okay, acute coronary syndrome, which we also call ACS. General information about acute coronary syndrome: reduce blood flow, myocardial oxygen supply decrease, and which lead to the imbalance of the demands. So heart muscle couldn't get enough blood, which simply mean couldn't get enough oxygen to work, caused by plaque buildup in arteries, which is we can call atherosclerosis, or the fatty streaks buildup leading to clots or ischemia. There are stable clots and non-stable clots. If the clots is not stable and they go through all over the arteries, through arteries, then we call it non-stable clot. So it is divided into NST or STMI. So if the condition is NSTE, ACS is unstable angina, which we also call, which is because the clot is unstable. If the condition is STEMI, leads to ST elevation, which lead to ST elevation. So here you can get, if the condition is UA and STEMI, what the patient suffer. In any condition, the patient got chest pain. Okay, and what is about cardiac enzyme? If the condition is UA, the patient, unstable angina, there is no cardiac enzyme release. But if the condition is NSTMI and STMI, there is the release of the cardiac enzyme, which we are talking about the last chapter in angina, the troponin protein and CKD-MI. What about ECG changes? In UA and unstable, the non-transit ischemic changes, ST depression, T wave inversion. But if the condition is stable MI, then ST segment lead to increase. The wave is upward. What is about blockage? There is a partial blockage in unstable and known STMI, and there is a complete STMI is stable, mean the complete blockage, because the clot is stable in that area. So what are the diagnoses? 12D ECG with 10 minutes. Medical contact. Patient with MI need to be taken to hospital with PCI capability. Cardiac enzyme like troponin 1 and T are biomarkers for ACS, like acute coronary syndrome. Must have 3 to 6 hours after serious onset. CKMA or myoglobin may also be used. These are also the test enzyme. Sign and symptom: chest pain, pressure, chest tightness, dyspnea, diaphoresis, syncope, palpitation, and pain may radiate to arms. It's like an angina, but it's more serious. Back, neck, or epigastric area. So there is how we can relate. If you are suffering with angina or MI or any heart disease, it's lead to like a digestive system. You got an epigastric pain. It seems like you have a gas or bloating issue, but this is a serious condition. So you need to take emergency, or you should take action if you are suffering with these kind of symptoms. This is not a normal symptom. If especially you are a heart patient, or is there any surrounding or the history in your family about the heart disease or cardiac arrest, or if you are in stress environment, so you need to notice these things, or for the loved ones. Can occur at rest with little exertion or caused by exercise or stress. What are the risk factors? Men 45 is least and above, women 55 above. फैमिली हिस्ट्री फर्स्ट डिग्री मेन 55 मोर है नीचे, वुमेन 65 से कम, स्मोकिंग, हाइपरटेंशन, डिसलिपिडीमिया, diabetes if the real lipidemia is like in blood. So obviously lipids profile, obviously the clot is form of lipids. Diabetes, chronic angina, CAD, and sedentary EDUH use, like you are using alcohol, you are drinking. So there is a mnemonic: Mona, Gab, B, morphine, oxygen, nitrate, aspirin. Mona. Okay. Never use NSAID other than acetylsalicylic acid aspirin in hospital setting. Okay. No NSAID. So what is GAP? GAP is GP2B or 3A antagonist. We have to target this. Any anti-A for anticoagulant, which is LMWH for non-STMI, UFH is or biovirutin, or for STEMI or warfarin use may use laser goal of 2 to 2.5. Use for shortest time possible. PPI should be given to all patients with history of GI bleed or triple ABX. You should test your PPI. Proton pump inhibitor. You should take the medicine. P for P2Y12 inhibitors. B and BA. Amona, GABA. B for beta blockers. Intrarectal nifedipine, never used. And the last is ACE inhibitor. So these are the drugs. Mona, GABA. This is very good mnemonic for you to remind these drugs. So drug therapy, all patients should get high intensity statin. For non-STMI, monogab BA plus minus PCI. If the patient is STEM, we use N-STEM and STEM term. Monogab BA plus PCI is mandatory for a stable condition. Or fibrinolytic plus PCI preferred है, but you can use fibrinolytic as well. Okay. Fibrinolytics used if patient isn't able to get PCI within 2 hours of first contact. If the patient couldn't get PTI, so the fibrinolytic is best fit to use. TP surgery is also a good option for those patients. For the long-term management after ACS, second, prevention, acute coronary syndrome, aspirin or ASA 81 mg QD for life, like one time a day. P2Y12 is a ticagrelor or clopidogrel plus ASA for 12 months if you are taking with aspirin. And PCI patient, prasugrel, ticagrelor or clopidogrel plus aspirin for 12 months. NTG for life, nitroglycerin for life spray or aceblecoil, you can use either. Beta blocker for 3 years or lifetime if hypertension or heart failure condition. Oxygen, blood pressure, heart rate, ischemia decrease. Patient PO low dose beta 1 yani oral selective beta blocker with ISA activity preferred, started with 24 hours. Within 24 hours, if beta blocker is contraindicated, use known DHNP, it's calcium channel blocker, verapamil or diltiazem, ACE or ARBs for lifetime in all patients with LVEF 40%, less than 40%, hypertension, diabetes mellitus, CKD. Oral start within 24 hours for a lifetime if the patient is LVEF is a rejection fraction lower than 40%. left ventricle ejection fraction. It's talking about left ventricle LV. Statin high. If 70% or more than 70% air patient. Moderate if 75 air, less than 75 air patient. You use moderate statin, and if the 70 above 7 age is 75 year above, then use high dose of statins. Okay, so you can use in morphine sulfate with mechanism of action: arterial and venous dilation, decrease oxygen demand, ADRs, hypotension, bradycardia, sedation, respiratory depression, NV, and nodes. May be used with or without nitroglycerin 2 to 5 mg IV Q2 30 minutes PRN. Oxygen given if oxygen saturation less than 90% and respiratory distress condition. Nitrates dilate coronary arteries. You can use it. Oxygen demand decrease, preload decrease. Systolic blood pressure less than 90, heart rate less than 50, right ventricle infarction. Never use with PDE5 inhibitors. You can use nitroglycerin with PDE5 inhibitor. The reason behind it we have mentioned earlier in hypertensive slide. Aspirin. Irreversible COX-1 and 2 inhibit TXA2. Never use ER, ASA, ASA products, and maintain 81 to 162 mg for life. 81 to 162 mg for life. You need to maintain in between this range. Non-enteric coated chewable ASA 162 to 325 mg for all patients. Non-enteric coated. Abscisimas is Rio Pro and eptifibatide, integrilin, tyrofibon, agrastate, which is GP2B or 3A antagonist, block fibrinogen, inhibits platelet aggregation. IDRs, bleeding, thrombocytopenia, hypertension. Okay, contraindicated in thrombocytopenia patient, platelet less than 1 lakh. History of bleeding, stroke, uncontrolled hypertension, recent surgery or trauma. Notes: not for medical management. If used in PCI, must be given with heparin, and abscisimas must be filtered for reconstitution. Clopidogrel, which is available with Plavix, or prasugrel, which is available with Efficient, and these called thenopyridines, prodrug that bind with irreversibly to P2Y12 receptors, given with the acetyl, which is called DAPT, and ADRs, bleeding, hematoma, and pruritus. And contraindicated in serious bleeding patients, serious bleed, history of TIA or stroke only, and stop 5 days before surgery. Avoid omeprazole, esomeprazole, or CPC19 inhibitors. TIP has been reported in clotting risk increase. Only given if PCI. Keep in OG container. OG container is pack container, which is about prasugrel, not used for patients more than less than not used in 75-year-old patient. Whose age is below 75-year-old, not used in those patients. Okay. Brilinta is ticagrelor, Cangrel is Congrelor. P2Y12 inhibitors inhibit receptors, prevent platelet aggregation, the same areas: bleeding, hematoma, pruritus. Serious bleeding, aspirin if 100 mg above dose must avoid. Ticagrelor due to decrease effectiveness. Serious bleeds for history of ICH is ischemia condition. Stop 5 days before surgery. Not a prodrug. Maintenance dose 90 mg BD for 1 year. After 1 year 60 mg BD. So if you are talking about Congrelor or Cangrel, transition to oral P2Y12, ticagrelor 180 mg can be given during or after stopping Cangrelor. and cannula infusion, but prasugrel 60 mg or clopidogrel 600 mg only after cannula, not. Okay, the last is alteplase, which is available Activase, tenecteplase, TNKs, retiplase, which is available with Ritavase. So these are the fibrinolytic drugs convert plasminogen into plasmin only for STEMI, stable STEMI. I hope you are clear with STEMI and non-ST. This is I have earlier the basic term, which is a stable or non-stable. It is also related to the if you are checking your ECG, then there is a waves, ST, Q wave and P waves. So if the ST wave is elevated, this is called STEMI. This ST elevated MI. If the ST wave is not elevated, it is called unknown ST elevated. So ST is a segment on your ECG. So if ST wave is elevated, then it's called STE. If not elevated, then it's called known STE. So their areas is bleeding, intracranial hemorrhage, hypertension. Only given if STEMI or unable to perform PCI in 90 to 120 minutes में अगर आप PCI perform नहीं कर सकते, then you can give it. Must be given within 30 minutes में आपने देना है जैसे पेशेंट को अटैक होता है. हिस्ट्री ऑफ ICH कॉन्ट्राइंडिकेशन, अगर इस्केमिक हार्ट डिजीज की कंडीशन की हिस्ट्री है तो नहीं देना. ब्लीडिंग स्ट्रोक की हिस्ट्री है तो नहीं देना. अनकंट्रोल्ड हाइपरटेंशन नहीं देना. रीसेंट सर्जरी और ट्रॉमा है तो नहीं देनी है. डार्ट टू नीडल 30 मिनट्स इससे कम के अंदर जो है वो आपने दे देना है. So this is a short and brief and most important information about coronary artery disease, which we artery syndrome, which we also call it, which we have discussed. And if you like this video and you want me to make more videos, please subscribe my channel and also mention your thoughts and suggestions in comments. Thank you. Allah Hafiz, until next time.